following of the appendix are sharing the common sensory route with the nerve or cutaneous nerve around the umbilicus. At the onset of appendiceal inflammation, the pain usually localized around the umbilicus. Then with advancing inflammatory process and more localization of the pain, it will be felt usually in the right iliac fossa. This lady found to have low-grade fever, 38.5 degrees Celsius. The pulse rate is 90 at the upper limits. Respiratory rate 18, and the pulse blood pressure 100/70, which is normal for her age. Now, to reach a diagnosis, we have to ask for some laboratory tests or investigations. The most simple and available one is the complete blood count, specifically for the white cell count, which is here 11.5, with around 76% polymorphs, neutrophils, and just 14% lymphocytes. This differential count means that the reaction is mainly neutrophilic. As you know, neutrophilic reaction usually occur towards bacterial infection. Also, we have to ask for pregnancy test because the patient is a young lady in her reproductive age, and the possibility of ectopic pregnancy is still a valid differential diagnosis. Stool sample for occult blood should be asked for to exclude inflammatory bowel disease or infectious causes like amoebiasis or other infectious causes of abdominal pain. Also, urine analysis should be requested to exclude urinary tract infections. If the urine analysis, stool sample, and pregnancy test all are negative with high leukocytic count, mainly neutrophilic reaction, and the clinical picture of appendicitis, the most likely diagnosis is acute appendicitis. Acute appendicitis is a common condition. It's more common in younger age group, especially children. Usually it occurs either due to obstructive causes or non-obstructive causes. The obstruction usually occurs due to impaction of fecolith, lead to obliteration of the lumen, accumulation of secretions, and secondary bacterial infection afterward. Other investigations which might help to confirm the diagnosis, like ultrasound, to rule out the possibility of ovarian cysts or torted ovarian cysts. CT scan also might help to detect any periappendiceal masses or right iliac fossa masses. Laparoscopy can be used, but actually it's rarely used. After the surgical intervention, the excised appendix should be sent for histopathologic examination. This is CT scan. Here it is obvious that the appendiceal wall is markedly thickened. This is the lumen. The black dot here represents the lumen. You can notice easily that the rest of the lumen is obliterated. The wall is markedly thickened due to edema and inflammatory reaction. The soft tissue or fat surrounding the appendix appears here with multiple linear streaks which represent edematous surrounding soft tissue. Gross examination of the excised appendix revealed that the outer surface, which is covered by serosa, is markedly opaque due to accumulation of fibrin and inflammatory exudate. You know that the appendix is covered by serosa, which should be or should appear translucent or glistening normally on gross examination, but due to the inflammation and accumulation of fibrin and exudate, the appearance turned out into opaque gray white surface. The lining mucosa here is inflamed with this pus replacing the mucosal lining and these areas of ulceration. On histological examination, this section represents the whole thickness or transmural thickness of the appendiceal wall. This is the mucosal lining with the lymphoid tissue aggregate within the mucosa and submucosa. The submucosa here appears edematous and expanded by edema and inflammatory cells. Large portion of the mucosa actually is lost due to the inflammatory process, and it gets left out into the lumen. The inflammatory cells are infiltrating through the muscularis propria into the outer serosal surface with congested and dilated vascular spaces. These are the neutrophils transecting through the muscularis propria, which confirm the diagnosis of acute suppurative appendicitis. Now, if this lady came late to the emergency department, or she didn't seek medical advice at all, what the outcome of acute appendicitis? Usually these cases end up by acute peritonitis and abscess formation, which might lead to septic shock and eventually end up by death in about 2% of cases. The differential diagnosis of acute appendicitis is largely dependent on the anatomical or the organs within this anatomical area. As you know, the right iliac fossa is the site of appendix as well as the terminal ileum and cecum. Also, the ureter is passing through the right iliac fossa. In females, ovaries and fallopian tubes also are there. So all these organs should be considered whenever you have a case of right iliac fossa pain. If the fallopian tubes are involved in the inflammatory process, it's most likely to be salpingitis as a part of inflammatory bowel disease, or the more serious scenario, which is ectopic pregnancy. The normal pregnancy usually occur within the endometrial cavity, but in some circumstances, the fertilization and implantation occur within the fallopian tube as the pregnancy gets advanced and with increasing the size of embryo, usually around the age of 6 to 7 weeks of gestation, the fallopian tube cannot withstand the large size of embryo and actually get ruptured with major or massive internal bleeding into the peritoneal cavity, which might lead to death of the mother. So the right iliac fossa pain is surgical emergency and should be considered as an acute case, and acute ectopic pregnancy should be ruled out as early as possible. This is the histological appearance of acute salpingitis. This papillary projection represents the plica, which is the part of the fimbrial end of the fallopian tube line, which is covered by a simple columnar epithelium. You see here that the neutrophils are infiltrating through the lamina propria, attacking the lining epithelium and surrounding these plica. This picture is representative of acute salmongitis.
Sorry, I'm having trouble with the connection. Please try again in a moment.
This is a uterine corpus, and this is uterine cervix. These are both fallopian tubes, and this is attached cystic or ovarian cyst attached to the fallopian tube. With increasing the size of ovarian cyst, usually they might get torted, which lead to occlusion of the blood supply and end up by infarction, which might represent by acute right or left iliac fossa vein, similar to that of acute appendicitis. The only line of treatment is surgical intervention. No rule for medical therapy for acute appendicitis. Whenever you have a case of acute appendicitis, you should go in and remove it and don't leave it for the possibility of perforation, peritonitis, and septic shock. Any question about appendicitis? Okay, the second case. Here we have a 4-year-old child presented with 3 weeks history. 3 weeks history means about 20 days, which is a long period. It's long enough to consider it as a chronic process rather than acute process. The complaint of this patient is cough, loss of appetite, night sweat, and persistent fever. Fever and night sweats are suggestive of inflammatory process. However, they might be seen in neoplastic disease as well. But in a 4-year-old child, it's more suggestive of inflammatory process. The cough also is a symptom of involvement of the respiratory tract, which might raise the possibility of respiratory tract infection in this child. On physical examination, also, he found to have cervical lymphadenopathy and decreased breath sounds and crackles over the lung fields. Decreased breath sounds in case of respiratory tract infection occur due to obstruction of the airways, which interfere with the entrance of air into the lung fields, and the crackles usually occur due to the interaction between air and the secretions and mucus and fluids within the inflamed lung parenchyma, and which is appear as the crackles on auscultation. This child also found to have low-grade fever with 38.7 degrees Celsius. His pulse rate is at the upper limit with tachypnea. 28 is a high respiratory rate actually. As well, the most available and important investigation is complete blood count, especially for the white cell count, which is here about 11.5, with around 50% polymorphs and another 50% of lymphocytes. Here the lymphocytes are increased, which suggestive of either viral infection or microbacterial infection. As you know, bacterial infection usually manifested as neutrophilic reaction, while viral or mycobacterial infection lead to lymphocyte predominance as an inflammatory cells. On chest X-ray, there is a right-sided pleural effusion. This is the appearance of pleural effusion. This is the right lung field, and this is the left lung field. This is the heart shadow, this is the mediastinum, and this is the trachea. This angle, known as the costophrenic angle, it lies between the ribs and the diaphragm, so it's known as costophrenic angle. As you know, or as you see here, skin and filled by air. The air appears black on chest X-ray, while on the other side it is obliterated and appears white up to the middle of the right lung. So obliteration of the costophrenic angle on chest X-ray means that there is accumulation of fluid, which is known as pleural effusion. Also, there is hilar lymphadenopathy, as you see here, and these streaks going spreading all over the lung parenchyma represent consolidation of the lung parenchyma, which is consistent with pneumonia. The most likely diagnosis here is pneumonia due to bacterial causes, which is the most common cause of respiratory tract infection in children. As you know, bacterial infection should be treated with antibiotics. But this child, and despite being treated with antibiotics and antipyretics, the symptoms persist, and this is why we should consider tuberculosis as a differential diagnosis. How to confirm diagnosis of tuberculosis? Either by tuberculin skin test, tuberculosis PCR, or applying the Nielsen stain into tissue sections either from the lung or pleura to demonstrate acid-fast bacilli within the caseating granulomatous reaction. This is the process of tuberculin skin test by introducing the PBD into the subcutaneous tissue, leaving it for 48 or 72 hours, then observe for the erythematous reaction, measure the diameter of erythematous reaction, and consider any induration or ulceration of the surface to make up your diagnosis, either positive tuberculin test or negative tuberculin test. On tissue sections, usually the histological features of tuberculosis is caseating granulomatous inflammation. What's meant by granuloma is accumulation of inflammatory cells. Caseation means this necrotic material in the center of granuloma. It is the granular eosinophilic material accumulated in the center, surrounded by lymphocytes with the scattered Langerhans giant cells or multinucleated giant cells. On application of ZN stain or Nielsen stain, the acid-fast bacilli appears red and elongated on a blue background of the necrotic material. Tuberculosis is a very common and widely distributed infectious disease due to infection by Mycobacterium tuberculosis. It's an airborne disease. Around 1.7 billion cases are present worldwide, and most of the persons infected with Mycobacterium tuberculosis are immune-compromised patients. Any questions?